to the GCACH board meeting. So let's start the meeting by asking everyone to review for themselves the attestation of the conflict of interest and the self-dealing transactions. And just looking from the agenda, if anyone would like to address whether or not they believe they have a conflict on any of these agenda items, that would be great. Seeing none, then why don't we go ahead and do introductions. Do we have anybody on the phone? We do. Okay, so let's do introductions so that people know who's here. So I'm Rhonda Hoff with Yakima Neighborhood Health Services, chairing this board and representing the housing sector.
Carol Moser, Executive Director, Greater Columbia.
Madeline Carlson, People for People, representing transportation.
Vera Foster from Experience Langside Hospital.
Wes Lucky, I'm the Deputy Director for the Greater Columbia.
Megan DeBolt, Wallowa County, representing public health.
Candace Flores, Yakima Valley Farmer Group Clinic, representing F2HC.
Wes Stallmaker, Education Services, 123 for education.
Christine Fernandez, Greater Columbia.
Lauren Johnson, Greater Columbia.
Ruben Peralta, Community and File Engagement Specialist, Greater Columbia.
Julie Peterson, to Death Valley Healthcare Hospital.
Diane Halo, Greater Columbia.
Anthony Sanchez, Greater Columbia.
Jenna Shelton, Greater Columbia. Becky Cole, Greater Columbia. Sam Murnell, Greater Columbia.
Terry Green, Three Rivers Community Foundation, representing philanthropy.
Brian Gibbons, CEO of Sunnyside, treasurer of this board, and representing
Ruben Alvarado with City of Pasco, representing local government.
Marissa Ingalls for Native Care, a survey.
And who do we have on the phone?
Siobhan Brown from Houston.
So let's do that one. Let's do that. Let's try that again. Yeah, thank you, Laura. I'm going to turn you up a little bit. So let's just go by the name. So there's Dan who's on the phone.
Dan is on the phone from the center in Portland.
Okay, thank you. And Siobhan?
Siobhan Brown, Community Health Plan of Washington.
Thank you. Is there anybody below her on that list, Lauren? No, I see that. I was just trying to go with the names first, and then we can. Okay, so we have two other people, caller number 1 and caller number 3. So how about if you, would you please tell us who you are?
Tanya Chris with the Yakima Nation.
Thank you, Tanya. And is there anyone else?
Martha Landman.
Okay, Martha. Thank you. Is there anyone else on the phone? Okay, well, thank you all for being here. We officially do have a quorum. So the first item is the consent agenda, which is the board minutes from September the 20th. Just one item on there. So hopefully you've all had a chance to review the minutes.
I was in the minutes of the board meeting on September 20th.
Thank you. That was Julie. Do I have a second? Second by Megan. Any discussion? All in favor?
Aye.
Anyone opposed? I know. It's like 10 jumping jacks for you. So run the room. Okay, so are there any abstentions? Okay, the minutes are approved. Thank you very much. Okay, so we're going to the ACH reported update. So Carol, you want to take the lead on that?
So the staff has put their names beside each article. So I will just let the staff go around and we can go through the report very quickly. I guess the first is written by Jen Shelton.
So this is just a summary of our October month, written from the kind of perspective of the end of the month. It's been a very busy month. It'll be a very busy month by the end of the month. We're still working with the Patient-Centered Medical Home Organization for Practice Transformation, also with the Behavioral Health Agency for IMC. We've been getting a little more in depth with our work at some of our organizations, which has been really fun. We've been doing kickoff meetings as well as doing the CCMHA assessments, which has been good. We've gotten really good feedback from all the organizations who we've worked with. They're excited. Most of them now know why they're excited. I mentioned earlier we got called a road show, which is very appropriate. And it's just been really good. We're going to the VHO symposium on the 22nd in Yakima, so that way we can be available for the Medicaid symposium in Seattle on the 23rd and 24th. Yes.
Shannon, may I, in my organization, we have a couple of new people. I was visiting with our practice administrator. Anyways, new position, very, very nice guy, he was Jay. And that we were moving that the GCHGH was moving through the Medicaid transformation project, espousing the PCMH model for all of our stuff. And are you the person who I might connect with to help us, again, I see your title as navigator, so navigate those waters. Are you the guy or is there someone else? So, but are you the appropriate person for me to connect Jay with, or is there another party?
Me or Martine, and or Martine.
Excellent. Thank you very much. I'm happy to connect you guys. You all.
We can just say y'all, and it'll make me y'all.
We weren't going to say it, but we do it.
Thank you very much.
Okay, so report from the executive portal. A little update from the last month. We're still, as Jenna talked about in her article, working with the BHO to get them paid for their rehab and their billing toolkit. The last few little stragglers from the LOI and getting registered in the portal, Brian.
No, it's not Brian, that's
Mike.
I've mentioned it to Mike a number of times. Now, there is back, so we can lean on Mike.
We're glad you're back.
Nobody is more bad if Sarah's back tonight.
So anyways, in closing, we've paid out $380,000 from the portal so far, and we have a lot more to go.
Okay.
So the Tri-Cities Alliance for the Common Good is gathering a panel of experts on addiction to share their knowledge and jumpstart a conversation about what people in our community can do to end opioid abuse and start healing our families and neighborhoods. This group will be planning to meet Monday, October 29th, and then I put the location, the time, and the address if you're interested. And then there are free webinars that Collective Medical Technologies is hosting. Eddie and Pre-Manage are the two, and if you are interested, I included their phone number and the WebEx meeting link for both of those.
So for the item C, we've been busy. So the healthcare authority sent out letters to the clients letting them know that there's going to be changes to their plans. So the INC Communications Work Group has put together about 4 documents that are available to help with this question. One's geared towards the providers, one is geared towards the consumer, and it's translated into Spanish as well. And then there's also a frequency package. So I have them all out to the behavioral health providers as well as to all the navigators in the area in all of our counties.
The insurance navigators.
Yeah, no, the navigators for the health
Benefits exchange.
The insurance.
Or in-person assisters, they have something like that.
And then, so we're just trying to get that information out. There's going to be a letter coming about the 20th of November, letting them know which NPOs are being assigned to. And then at that time, you have a chance to change it if they want to. They're really focusing on the United Healthcare one so that they can transition to the new NPO. So a lot of providers have been reaching out.
So for your handout, that you've developed? Is there a reason you wouldn't share those with all the
Yeah,
stakeholders?
we definitely need to, I can send them out. In fact, I want to send them all out to all of our providers. That way that even the primary care providers have them.
So United Health not in this region at all, not just for behavioral health, for every,
Yeah.
January 1.
For Medicaid.
Except for the dual.
So they'll just be assigned a new MCO as of November 20th, and then they have a chance to change it if they want, but it'll be effective as of January 1st.
So Rhonda commented that the exception to that would be for eligible.
Medicare.
And then isn't there some testing of the billing
Yeah, there's
claims?
going to be some types, well, they're gonna have their MCOs are having their symposium next week. So they'll meet with all the providers to help go over the clinical and billing for each of the MCOs to help them get ready. We'll hopefully and then also making sure that all the providers have their NPI numbers and put it into the healthcare system. As the early warning system workers has been working on the indicators, I think we're just going to go with the standard indicators that the healthcare authorities have put together. Hoping that they're supposed to have a meeting with the NCOs to kind of develop some of the provider information, like the denials or some of the administrative stuff regarding like payments for the claims and things like that. So as soon as we get those back, if there's a couple that we feel that we might need the providers to provide to us, then we'll discuss that at our next meeting. On the provider readiness work group, we're going to actually have a meeting today, and they're going to go over the jury guide and the frequently asked questions that were they had a webinar on the jury guide on the 5th, and so they're going to go over the questions on that. And then just remind everybody about their symposium.
What do you, Siri guide? What do you?
The jury guide has a lot of the information on like the codes and taxonomy and things like that. There's all different. I'm not sure exactly all the stuff that's involved in it, but there's a lot of information. I can send it to you.
Does that come from the plans or the state or
It
where?
comes from the healthcare authority.
No, I don't want to see it.
They had a whole webinar on it, and I if anybody needs to like, we also can put it on ours as well. I have most of any of our meeting minutes and all of our materials all on our website. So that's our summary for items.
So I'm curious, how's it going with the behavioral health providers and getting?
I want to say, there's this in your packet, it's called the tracker. This is kind of where we're at. So we met with 16 of the 17, so we have the last one is Triumph. We're meeting with them on the 30th. We've completed all of their NEHAS and the billing toolkit. They are all pretty ready. So far we paid out 11 of the NEHAS and billing toolkit. 11 providers, so they're submitting their budgets and trying to get them all into it so that we can get them the rest of their funding. And so that's kind of where we're at. Well, this is just the incentive fund. This is, all their incentive funding. So as soon as they do their practice, their PCIW, their practice transformation work plan with the navigators, we get that approved, and then they submit their budgets and they come to the rest of their funding. So we're just need to kind of go through the budgets and what they're using their funding for. So we're on the right track. Yeah,
You guys have done a lot.
We've done a lot of work. Actually, these guys have been great. It's been really nice having a team of people together. And in fact, we went to a mayor group thing, and everybody was like, "Oh, it's so good to see you guys today." I think they really appreciate the one-on-one that we do with them.
I think we're really fortunate, Megan, in that the healthcare authority asked if we wanted to take over this contract. And I think it just came at the right time. The navigators were fairly new, and so this gave them a chance to get out into the community to kind of hone their skills and all the things that they had learned through the curriculum. It's a little bit less daunting than practice transformation, the PCMH. But I just feel like we have been able to make a very strong connection with all the providers in the area, which has facilitated then these conversations about integrating services. So the navigators are really good about saying, oh, have you thought about, bringing in mental health or bringing in primary care? Do you realize that you can get reimbursed for that? And so I think it's really facilitated some good discussion, but it's also given them this hands-on experience, and that people have been responding really, really well because we've got these coaches, out in the community. So I'm starting to hear from some of the other ACHs that, well, we're gonna have coaches out in the community too. So it started a little bit of friendly competition around the one-on-one service that we're providing to our providers.
I'm sure it's provided some, ease of nerves too for a lot of the providers. They were nervous at going to just conversations with the DHO. Very cool. And Bart's is doing good. It was Bart's clinic who was here, right? Yeah, they actually already have their budget submitted, and they've been following everything.
I just wanted to give a compliment to Martine and Jenna, because I actually got to sit in on one of the IMC meetings that they had with my organization, and they do a very good job of calming everyone and being like, okay, well, if we needed, okay, they have a really good understanding that it is a little overwhelming when we don't always necessarily understand things, and they do a great job of talking everyone through things and what it really means when you say this or that, and making it easier for everyone to be like, oh, okay, this is not as bad as I thought it would be. So you guys did a great job. I wanted to compliment you on that.
Yay! Good job. That's why you guys get to wear the cape. So as everybody knows, we sent out the notice that we had received 100% on our semi-annual report. Yay! So we got one half of the funding that we should be getting, or we will get one half of the funding that we should be getting for 2018. So we're kind of on a funky cycle, is that we haven't gotten the money yet. That should be around $11.5 million. And then the second half of 2018 doesn't come actually until next year. So when we talk about budgeting, it's very confusing to talk about, well, when did the dollars come in and what are they supposed to be used for? But we're hoping that if we score as well on the second semi-annual report in February, it's not worth quite as much. It's actually only worth 18 achievement values, these AVs. And then our implementation plan is worth 1 AV. So staff is working through the budget for 2019, anticipating that we will score at least 90% on that next STAR. So we're looking at about $21 million for 2018 for our 2019 budget, if that makes sense. And then just a little bit about the semi-annual report. I think it ended up being about 84 pages. So these are not small documents. It's posted online. And we had to go through really an intensive look at the current state assessment. That was one of the main deliverables for the report. And then looking at domain 1 strategies. How are we addressing value-based payment? How are we addressing workforce and population health management? So that was the bulk of it. And then the implementation plan, I'm hoping to hear fairly soon of how well we did. The good news is that we haven't had any news from Myers and Stoffer saying you have some write-back opportunities. And I have heard that there was another ACH that's already gotten some write-backs on their implementation plan. So hopefully we've completed that and we won't have to go back and do any more write-backs.
Other ACHs had write-backs on their SARs too, and we didn't have any requests for that. And just a bit of history, when we did our project plan, that's Point Fingers and Outside Consultants HMA. All the questions that they wrote, there were write-backs. The ones that we wrote went through. So I think we do a better job of that process, although it is.
Our ACE is expert.
Oh. Well, today, and the reason why I wrote my article around ACE is in today's leadership council, most of them were hearing part of it. They were going to report, and part of their report involved social determinants of health. And ACEs are just 10 of those hundreds of social determinants of health. So So in addition to what the LINs are doing locally, we, as an ACH, we are exploring ways of addressing those specific things most determinants of health cases. And the more and more, and just last night I came back from San Francisco. I attended the Access to Action AIDS conference, and Dr. Vincent Politi, one of the two researchers, was there, and Dr. Nadine Bird Harris. The one probably the advocate that has pretty much advanced the AIDS movement more than anyone else. And attending this conference and the one I attended in Nashville last week pretty much confirms that we should work with existing efforts to bring awareness and also to help with some capacity, perhaps, resilience building programs. They have Strengthening Families was here earlier today, business school programs like that, and other programs in housing. They help build get results in terms of health. So we need to figure out a way, some type of media campaign to educate the general public. That's one thing both of them say, is that just knowing about it, putting yourself in those 10 questions and how they might have affected you. Also to think about the rest of the family, think about what you put in your family, answer those questions for your children. That kind of stuff helps people a lot also. So we are exploring ways that we can provide some support throughout our region and bring awareness directly to the general public. Because right now throughout the nation, most of the efforts around cases is training teachers, is training healthcare workers, is training social workers. Nothing is being done really directly to the general public. So we're working on that. We're hopefully something we're going to do together, and we're going to have a lot of the local communities to maybe consult with, or maybe they can provide us with some opinions or some ideas on how to craft messages.
Are you able to connect with Carrie?
Yes.
Okay, good.
Yes, and in my mind right now, I'm thinking just rather what she's doing and just expand it to the rest of the community. That's right now. There are so many efforts out there, so many groups. A lot of people are doing some wonderful work. And at this point, my perspective is our job should probably be to just help them expand, help them just take off and connect them. And just mean that yes, the fact that conductor, director, or whatever.
An inventory of that work would be really nice to see. I know we have the Community Resilience Initiative in Walla, which has been going on for a long time. It's been really successful, but they're even at that point now where they're like, okay, we've been talking about ACEs for so long, we need to move forward to hope and healing. And they're learning a lot right now about, ACEs and still holding individuals with ACEs, especially a lot of the work done at Lincoln High. There's still an accountability for your actions, and they're working on some of that now. So it's really interesting.
And really, Walla Walla, it's viewed throughout the country. I think that's one of the leaders in this area.
Yeah, a fellow from London or Europe somewhere here. It's like, where are you from?
I Whatcom County also showed up.
Oh, yeah.
So they are looking at new specific paper typers. Quoting so maybe why not take advantage that we have a very, very strong capable people here.
And it just started doing trainers. So my whole staff got trained to be trainers of ACEs and trauma informed care. It's really good that now they're expanding to build capacity. You talked about a lot of stuff like just social workers and healthcare workers.
the emphasis we've been putting on is much more not understanding ACEs, and we've done that, but how do you work with somebody who's suffering because of the experiences they've had, and how do you help them get from here over here, without just saying, oh my, yeah, that you actually have plans and things to do with people. And I think that's where the healthcare and what we're trying to do with teachers is to get them not just to understand it, but moving them to say, these are some of the things we can do, how we can help be successful.
I think the realization a lot of our organizations are coming to, the organizations that train the trainers, they're realizing that, wait a minute, we have ACEs here. We're going to be training, we're going to be teaching, helping people survive the ACEs, and we're going to teach them. So a lot of these organizations, as they prepare, as they learn about ACEs, it kind of triggers something, and they realize we're going to be out there working and helping people. We need to look at our organization first and make sure that we are trauma-informed, that we are working under a trauma-informed environment.
So
PCMH is no strong vein of conversation that's popping up.
PCMH in part, though, helps cover that by helping providers become educated in trauma-informed care. So I think we're dealing with that at the primary care level. We're at least trying to. And as well, the opioid resource networks. There was a great show on addiction last night on public television on Nova. They talked about individuals who score 5 or more questions on the standardized ACEs scoring tool have a much higher likelihood of going under substance abuse, becoming addicted to substance abuse. So there's a correlation there to our project area around opioid resource networks as well. So we're covering some of that.
Okay. Anything else, anything you want to highlight? Didn't fit into the report? Okay, so we'll move on to some action items then. So Becky, Brian, that's the combination you guys came up with under the finance.
So at the finance committee last week, Brian and I and Rhonda kind of talked about what to present to this group. Since I've come on, I guess it's different than what we did before. And so what we decided is that we are still providing the statement of activity and the detailed explanation of our expenses, but I'm not going to talk about all of that. But if you guys want to see it, you can read it. I'm just going to go over this document, the budget introduction, kind of highlight. This document shows our revenues, the actual and the budgeted revenue from our various accounts, and the kind of the new thing in this one is the STEM FY18 funding, the $34,190. That was some additional funding that we just drew down recently, and we used it to pay for the leases on the 2 cars that we talked to you guys about. And then in the expenditures, it shows our payroll expenses. Kind of getting, like Carol mentioned, we're kind of working on our budget now. We're kind of looking at what we spent on the payroll for this year and anticipating growing for next year and what we might need to increase our payroll expenses for sure, our operating expenses as well. We'll have new offices and if we hire people. Our travel and meetings expenses are on there. Another thing that we've been looking at is what things that we budgeted for and we actually use. You can see in the other services and miscellaneous, we have used $25,000, but we budgeted a lot more. So we're hoping to get this year's budget was kind of a first year trial run. Next year, we're hoping to kind of get the numbers down towards our actuals.
But you might mention what is your $800,000 had a budget on that one line. One of the things we talked about was what that entailed, and we had left a pile of money in there under the intent, right? And you potentially using them for IT services, EHR. Sorry.
Was requested by.
It was Question. So in the other services and miscellaneous services costs, we were $800,000 ahead of budget. So we're way ahead. And the conversation was, why are we so far ahead? Believe that what we had done was anticipated a need for EHR expansion and support. Ultimately, we did not need to do that. We were able to bring most of that work in-house, and so we find that big positive budget variance. I like to see big positive budget. So then we had some discussion about what to do with that money, and I think we found some other opportunities, some other funding opportunities to accommodate what we want to do. We'll speak to that here in a minute, so I'll just go back to what you.
Okay.
Thank you.
Thank you, Brian.
I don't think it's working.
Good.
I think it might be good.
Better still. I like it. Okay.
I'll talk loud.
Okay.
Give me that.
Okay, so going on down the budget versus actuals, the next slot is our expenses out of our STEM funding, and that is payroll for Diane and her traveling. Next box is more expenditures from the STEM funding. And then from our district funding for payroll, we have $323,000 that we've spent, and we have our budget was $966,000. That's the minimum that we quite a bit of money in there for. We talked about our community health funds. That hasn't changed. Food lunch activities expenditures, that's coming out of our Yakima Valley restricted funding that we have for the Yakima Foundation.
There was another item. We had actually a fairly lively conversation. It was about an hour-long meeting. And one of the things that we had talked about was expanding funds for the community health. Is that correct? The community health fund. And so we had talked about how do we felt like that had a great bang for the buck, and we had, with all of those dollars laying around, we thought maybe it might be useful to spend those dollars at, let the rubber actually hit the road instead of keeping it parked in our accounts. And so we had thought about that, and I think ultimately Carol and Becky were able to get back with us. There is a line item in the community health fund budget for reserves and contingency, correct?
Yeah.
And so you'll see that someplace. Yeah.
So just to clarify, so the district funds are what is being held in the financial executive portal. And when we make payments to our providers, it comes out of this particular fund. But we had these use categories for the community health fund, $997,600, and then a reserve fund or contingency fund at $853,000. Right. And so, and looking at that and seeing how much money we had left over, we approached the finance committee about perhaps double financing the community health fund.
Right, we're going to double up the community health fund and allow those dollars to get better use. And so we're going to look at making a recommendation to pull that from the other and miscellaneous on the budget. As we started looking at this, we saw it in the reserve area. I think the recommendation was, again, in that doubling, it was approximately $2/3 of $1 million, so $667,000 to be deployed back into that community health fund. And so ultimately, we think we can accomplish the same thing by moving those reserve funds, taking $667 out of those reserve funds and moving them into the community health fund in an effort to deploy resources. And I think that's a pretty good idea. Frankly, all that's happening here is you're just reallocating existing and already budgeted dollars. So I don't think there's a heck of a lot of action that has to happen, but I do think it's important for the board to understand those allocations and reallocations that allows allows the staff to do what they need to do there and accomplish that goal. So from that standpoint, I would think that is it. If we need to take action, I would certainly make it a motion.
We probably want to do two separate things because we need to approve the financials first.
Okay.
And then we could go to
We
the
can do this.
recommendation. So let me ask if there's any questions about the financials that Becky reviewed with us and that has been reviewed by the finance committee.
So they're voted with the motion to approve.
Yes, they will. But Brian has it.
Move forward with a motion to approve. They actually were. We had, well, there was additional discussion, and so probably I would recommend that we approve the financial statements, and I'd make a motion to approve the financial statements unless you all have any additional questions.
Okay. And who was that? Madeline. Okay, is there any further discussion about the financials? Seeing none, then I would ask for all those in favor to say aye enthusiastically. Aye. Anyone opposed? Any abstentions? Okay, so then you go ahead and make your second.
So I think we could, as we discussed in here, this discussion about the expansion of the community health fund. I think I would recommend, I would make a motion that we authorize the staff to move $667,000 out of the $852,000 contingency and reserve fund into, is it into the integration aspect? Or?
Yeah, and it's actually 697.
$697,000 into the integration category in an effort to provide those services closer.
So Brian, in the packet, there's a table that looks like this, that looks at the current distribution of the community health fund to the individual limbs, and the update which Brian is proposing to show the distribution by limb.
And also, Carrie, this is something that was discussed at the Budget and Funds Flow Committee that the Budget and Funds Flow Committee also approved. So it's been through a couple of different committees.
So would this be for the same time frame or is this extended?
This would be for a 2 year time,
So I think that's just an important thing for people to remember. So currently we were doing it for 1 year.
Right.
So this would allocate these dollars over a 2 year period.
Or I guess we could be convinced if they wanted to use them in 1 year, but it just allows us not to have to go through this process every single year. It makes, since we're so close to the end of the year, I think we were thinking originally that we'd be able to put the community health fund into action a little bit sooner, but it doesn't sound like it's going to happen until 2019 anyway. So this just gives us more money to work with.
So clarify the time period that these funds would be able to come in.
So these funds would be available depending on the grant cycle of the third-party administrator. They could be available immediately after signing the contract and after receiving the social determinant of health list from the LHIN. Or in the case of Yakima Valley Community Foundation, their cycle begins January 1st, and so that they would be available until March.
And then they could identify the use over a 2 year period of time from then, or does it need to be utilized within that year?
So if we wanted to go to the contract, we could talk about the contract right now.
I was trying to
identify
a rough time frame for it.
Right, and I think it's a 2 year cycle, Becky? Yeah. But it's all in the contract. So all of these things kind of meld together, the community health fund, the third party agreement, and then this transfer from the reserves into the community health fund. So they're kind of all morphed together. Yeah.
Right.
So do you have a motion you'd like to make?
Yes, I'd like to make a motion that we move $697,000 from the, right, 690?
697, 600, yeah.
697, 600, there it is. From the from the reserve fund to the community health fund for the LHIS.
Is there a second? And then I'm
Because
going to
as
ask
a
you.
win leader, we can vote or second or anything, so.
Yeah, I'm gonna be abstaining as well with the board member.
Okay.
But I thoroughly.
Okay, so is there anyone that does not have a conflict of interest that would like to second?
You know,
the motion?
I just want to say that I don't think that any board member here does have a conflict of interest because their funds are being distributed by a third-party administrator who will be deciding on the contract. So really, you guys don't have any conflict.
So Les had already seconded. You I appreciate the enthusiasm. Appreciate the enthusiasm. Is there any further discussion? Okay, if not, then all in favor?
Aye.
We haven't got to that point yet. So is there anyone opposed? And are there any abstentions?
Should I abstain on a possible situation?
Yes.
Oh, that's a good one. And what's her name?
And the MSO.
Caitlin.
Caitlin.
Abstain. Okay, great. Thank you very much.
Thank you.
For that direction. So the Numerica visa increase. Which of you?
Here, I can do that. So the Numerica visa, thank you. So the Numerica, thank you. Thank you very much. So the GCACH staff has a credit card, Numerica Visa, has a $5,000 spending limit on it. 2 people utilizing it for things like holidays and travel. And
Oh,
travel and so for some travel and for some conferences, things like that. And supplies, all the stuff. So it's a $5,000 limit. We've looked at it. It's at $5,000 given the size of this committee now, or this organization. That is too low. The Finance Committee has looked at that, and we would recommend moving that number up to a $10,000 limit on that account. So with that said, I would like to make a motion to move the credit limit up to $10,000.
Second that.
By Sandra, is there any further discussion or question?
You guys think that's enough? What's going on? But I know that in our agency, if we have one conference and enough people are going, it maxes it out really quick. So that's all. I'm just wondering if it's really enough, or if there needs to be some other support for that.
I'm comfortable even with greater support. We discussed moving it from 5 to 10 simply because that was what we discussed, and doubling it. I think if it turns into an issue, then we'll just raise it again.
Thank you.
Thank you.
Okay, any further discussion? All in favor?
Aye.
Anyone opposed? Anyone abstaining? Okay, there you go. Good job.
Thank you very much.
PCMH contract.
Okay, so this contract, I have been working with our transformation group there.
You're gonna have to talk to them about it.
So this is the Parks and Transportation Agreement. This is just a still in draft form. It's just kind of a preliminary document. So the reason I wanted to show this to you guys today is because the sections 1 through 18, I've been working with Topra, the local attorney, to kind of what we were trying to do is put together some standard contract language that we could use in all of our contracts moving forward, so that when we we don't have to bring, my hope is that we don't have to bring every contract to you guys every time, because we have the standard language that's been approved by a lawyer, and that, the working part with them to get this together. And so that this practice transformation agreement will be the first one that we use this standard language with. So that's why it's here. But again, the practice transformation part is still very, very draft form. We don't have all of the details that Sam and the navigators are working on, but that's why I wanted to show it to you guys today. I'd like to be able to use the sections 1 through 18 as a standard boilerplate.
So, on our mandatory thing, we have a federal paragraph in there that people aren't on some kind of list that can't participate in this. I forget the name of it. That one, but I didn't see that in here. I didn't know if you did it or not. Because they're dealing with money that comes through the feds, I think.
You're right. You're right.
Good catch.
I can probably show them. We have that in our standard contract.
I think I have that in our VHO contract.
It's even in our third-party administrator.
It is in our third-party administrator contract. Embarrassing, sorry.
No, it's fine. That was just the one
So with that addition,
online.
I would add that to this, so it would be 19 sections with that addition, and I'd like to propose that we make this a standard one.
Megan, you look like you want to say something.
Move to approve? I don't know. These notary? Because it says federal dollars? Okay.
We put, I just, we don't have to. I just have the notary in the VHO contract and the CPA, but that particular contract is at $2. Our attorney felt that it needs to be.
So not to be a Debbie Downer, but is there a place that speaks to non-performance and how we deal with it?
Determination language.
Here's an exhibit.
Would that be in this, or would that be in the amendments that this is attached to?
It would be an exhibit.
There's an item that's part of the document.
I think exhibits we have like before.
Yeah, in the section 12 is here.
Yeah.
Okay.
I'd like to move to approve with the addition of the department clause.
Okay, there's a motion from Megan. Is there a second?
Second.
Second by Brian. Any further discussion or comment?
It's because it's a big amount that we're trying to do this standardized thing. Is that what it is? Because you guys have done contracts before without.
Well, we bring all contracts for over $5,000 to the board, but I think that in this case, this is going to come back. It will be part of the boilerplate language for all of our contracts. So if there is something that we find between now and when we actually bring you the contracts for all of the provider organizations, we can make sure that we make those changes.
Kind of like a template.
So what we're doing is we're saying, this is the framework that we believe every contract should have at this time.
Yeah.
I understand that. Thank you.
And just clarifying, as far as now that we've talked about, federal funds, there's other exclusions for use of the funds and that type of thing. And I don't know if it needs to be included in this, like no lobbying, some of those federal certs and assurances that you're signing off in it. So that's only, and I don't know if you have to with this, but that would be my only.
Sometimes you'll have a special terms and conditions, like if it's for a specific funding source, it's even passed down through the funder, like if it's from Healthcare Authority, if they have some language in there. I know they do actually, because contract with Healthcare Authority, so you'd always pass down special terms and conditions.
So who's helping with this document? Do you have legal support on it?
I do, yep, and a little blurb in here.
I'll put Coke Rump is
Yeah,
there.
it's Coke Rump.
Section 13.
He's good with the manner in which you prepared the
I'm reading.
Okay, any further discussion before we vote? Are questions answered before we vote?
Oh, Rhonda, this is Lori.
Hi,
And
Lori.
I can't hear very well, but do the contracts, is there a maximum consideration per each contract? Like, for the payment amount?
Here, I think that would be in the exhibit and the addendums for each individual contract.
Yeah, so there'll be a
Okay.
section for the work, there'll be the payment, there'll be, Sam, for this particular contract she's working on right now, the deliverable, and there'll be a, this contract is very expensive. You guys saw the tracker, most of, everything is based off of that tracker. So, yes, there'll be exhibits. This is just a template, boilerplate, so that you guys don't have to read this. You know, and when you see a contract, you see this part, and you go, oh, I've already read that.
So Lori, did that answer your question?
Yes, thank you.
Rhonda, I have another.
Yep.
Sorry to do this. I thought I.
But you have to speak up.
But in section 13, there is a reference to a section 10.5 below. Got an underline under it, it's easy to find.
I see that.
So I just think maybe it's just a matter of figuring out how we get the referencing right. You know, this is great. I'm not trying to be picky about it, but.
No, that's correct.
Things I've noticed.
Be section 17.
Yep.
It's just the-
Detail.
Good job. Thank you. Look at that.
Okay. Any further discussion or questions?
This is the boilerplate, and then there will be like an SOW attached to it.
Yeah. Yeah, and deliverables and payment section and more details. This is just one.
There is that allowable expenditure section too, section 3, that in that Greater Columbia Metro contract. So,
So it could cover what you were thinking about.
Okay, are we ready to vote?
Yes.
All in favor of supporting the practice transformation agreement as the boilerplate template for contracts going forward, say aye. Anyone opposed? Any abstentions? Okay. Thank you very much. So I think we're going to make a slight modification on the agenda, and Patrick was here. Where did he go? He shut up. Okay, well, when he comes back.
I'll go grab him and we can start on that third phrase.
Okay, so let's go ahead and do the third-party administrator contract, and then we'll come back to Patrick when he comes in.
Okay, so the third-party administrator contract, Susan and I have been, and Carol, have been working on this extensively. We've gotten some guidance from some of the third-party administrators that most likely we'll be working with. We've seen some of their boilerplates and some of their contracts that they use, and we have a contract with one of the third-party administrators. So we kind of used all that in Ruben's knowledge and my knowledge, and switched it all together into this third-party administrator agreement. And this agreement does not have any of that standard boilerplate language that we've been following through, but mostly I think because it wouldn't fit. I mean, this is a very unique agreement. I'm sure Terry can attest to that. It was difficult. It was new for me. I hadn't written a contract like this before, so I enjoyed working with Ruben on it. I don't know if any of you have had a chance to look at it, but we reached out to some of the third-party administrators and asked them if we were going to use their contract or if they wanted us to create one, and most of them said that they wanted us to create one. So this is what we did, what we came up with. There's a lot of things, there's a couple of sections in here that you'll see they should be determined, and that's because once we actually start working with the third-party administrator and start negotiating some of these terms, some of these things are going to change.
So they're going to be dependent upon the region and the social determinants they decide to address. Right. So social determinants which, and Carrie can, elaborate more, it involves the donor. It involves the funder as an advisor. That's what, and we work, and I would be that advisor, and I would work with the Lynch to put together their decide what social determinants are, like area and one man.
So for a community foundation, the term donor advisor means the donor chooses the recipient, which is not going to be the case, correct?
So we were vacillating with that part of the agreement. So we need to change it to mean, to use the word that means that we're going to be advising, not so much choosing.
Yeah, so Carrie, we saw different contracts. So the Philadelphia Foundation called it a donor advice fund, and then Tri-Cities Community, Community Foundation called it a field of interest fund. So we have a little bracket depending on which third-party administrator and what their nomenclature is, that's what we will use in that piece of the contract.
Because for us, there are different IRS regulations for donor advised funds and area of interest.
Yeah, we'll use the language that the CPA uses, as long as it means that we're involved in the process.
Yeah, and for that reason, we will have our own agreement, and our own agreement lists the advisors. It's not, I made sure that.
Okay.
And I have a copy. And I made sure they agree.
Okay, good.
But it does list who the advisors are on the front.
Okay, so now I'm confused. So this was intended to be for the agreement between the ACH and the different TPAs.
Correct.
So, but based on what Carrie's saying, what we're also thinking about is that it's possible that there could be different contracts between the TPA, or between the ACH and the TPA. So it would be in addition to this?
Yes.
Would you still sign this one?
Yes, I would sign that
Okay,
one.
that's what I was.
All parties would sign both.
Okay.
It's just IRS.
Yes, no, appreciate your expertise on this, that's why I was asking.
So there's a supporting document in your packet that looks like this, which is a table which again is broken down by limbs that talks about the tentative list of TPAs chosen by each limb. There's also a column there that shows the administrative load for each of the TPAs. This is information.
And I'd just like to add that for those of us that from Yakima, we'll be discussing this at our coalition. This hasn't been decided on yet by our coalition.
So the tentative list.
So we just approved standard contract language, and now we're approving a draft contract that doesn't follow that contract language?
Yes, because well, they're different agreements, but the main reason is Ruben and I started this third-party agreement months ago. It's a long time ago. This was before I got connected with the lawyer and got No, thank you. And I think that this third-party administrator agreement is very different from what our standard agreements are going to be with our providers.
You need to have different perspectives.
Yeah, absolutely. I don't think that the TPAs would have signed that robust way. Yeah, so no, I think they're just different agreements. Yeah.
Any further discussion before we ask for a motion on this?
Yeah, they're different agreements.
Right, I think we've had different contracts, but I think maybe going forward, once we get the standard language clarified, if we see a little more consistency, so that it is just, for me, in my opinion, as somebody's had to do some contract management in my past life, it's easier if we're gonna say we're gonna have standard boilerplate, we try to follow that as quick as possible. I fully support using this kind.
Well, and just to clarify for you, Sandra, also you're right. If we have this standard language from when we did the DHL contract, if I had been here and we had that, it would have been used for that one already.
So
that's the kind of agreements that I'm thinking we're going to use them for. Agreements between GC, DHL, and providers, but it's third-party administrator agreement.
Right. No, I agree with that.
Would anyone like to make a motion?
That we approve. Draft. Second.
Second by Madeline. Any further discussion?
Clarification, so businesses, party agreements, all going through. They're coming back to us, do we see that final list and what's happening? Or are they, what happens after that?
So what happens after this
Yeah.
is let's take Three Rivers Community Foundation. We contract with Three Rivers Community Foundation, who works with the Benton Franklin Community Health Alliance, assuming that they have selected their social determinants of health. They bring in Ruben. They talk about, okay, so here's the priority list of social determinants of health. You guys use your process to send out your RFPs or whatever process you use. They come back. You can at any time meet together with Ruben, who's communicating with the LINs then, and say, we got X amount of proposals for housing, we got X amount of proposals for food insecurity or whatever that social determinant is. But we let the third-party administrator decide the awards based on the merit of the proposal, because that's what you guys do. And then after 6 months, we get a report back from the third-party administrator to say, we got back this many proposals, this is who won, and then after a year's time, then there's another report out from the third-party administrator on how much funding has actually gone out to support those different proposals. And then a yearly cycle after that. So this is a 2-year cycle, so we should have 3 reports within that 2-year cycle. 6 months, a year, and a year.
So when those contracts are made for party administrators, that doesn't come back here again because we've already done this. That's what I was, No, I just wanted to make sure that I understood.
And I think
how far this vote goes.
Right, and I think the key is that each LIN has kind of used its own process to gather social determinants of health. I think Yakima County did a great job in using the Prepare as a tool to get that feedback. I think Whitman County is actually using the Consumer Council. I think Kittitas, you guys have a Consumer Council that you've gathered. So just as long as we have the consumer voice, that's the thing that was required in the contract, is it has to be generated from a true need from the Medicaid consumers. That's not something that we're thinking up, but that we're getting feedback from the consumers.
I know Southeast Washington and us are doing their using the Prepare, but pared it down just a little. And they're out. They'll be at SMC, health fair, whoever.
Okay. Any other discussion or questions or comments? Then if not, all in favor?
Aye.
Is anyone opposed? And is anyone abstaining? Carrie. Great. Okay, so now I'm not going to turn around to see if Patrick left the room again. So I understand that you're going to give us a report on your meeting this morning.
Yeah, Carol, could you see it up a little bit now?
I was going to say, if you want to get a little closer to the phone.
So as our navigators have been out and about working with our behavioral health provider organizations, and as we've been working with Estrella Hospital in Toppenish to create a good system of care, a continuum of care, and as we've been working with the early warning systems group, the crisis system keeps coming back to us. You know, the provision of crisis services in Benton and Franklin counties, the provision of services in Yakima County. And so we decided, actually it was Estrella Toppenish, Joe Vela really was the kind of the mover and shaker in all of this, to suggest that, well, you know, let's have a community meeting. Let's hear from the community, because I think it's one thing to have a a comment coming from a provider organization or an ACH, but to hear from the community, what is the community saying? And I think that there was a little bit of concern on the part of Comprehensive that, you know, they had never heard really any criticisms about their performance. So, and so we felt like a community meeting was the best way to get some of that information out. And
different community meetings throughout the region.
Yeah. 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 So today's meeting was hosted by the Yakima Nation, who has felt that some of the services provided to them have not been, you know, as timely. And they have a particularly high suicide rate that is not necessarily being factored into the level of service that's being provided to the Yakima Nation. So I think that they were, you know, probably the strongest impetus for the reason for this community meeting. So they hosted it at Legends Casino. I thought it was very well attended. Patrick did a marvelous job of getting people's comments out. And I think it was a very positive, constructive meeting. So how's that for you, Patrick?
I think you covered it.
Okay.
Go. Okay, I'll just briefly go over some of the details of the tour. We had 80 people show up. Many of them tribal members, involved in the provision of care. We had some of the Latino community, which was great to see in Yakima because there's obviously big force. And we had HCA, two representatives. And then we had sort of a little panel in front where the people like HCA and Carol and the Comprehensive sort of gave their 3 to 5 minutes worth of what they thought was important.
And the Yakima Nation.
Yeah, obviously the Yakima Nation, sorry. Behavioral health group. And then we opened up for comment for about almost, hour and a half. It just went on. Sort of the agenda got a little shifted as we went on. We just sort of kept with all these comments, and we had a wonderful dialogue. My guess is, I don't know, those of you who were there, 20 people, 25 people spoke. We had a good back and forth between the people who were speaking from the audience and the experts or the people on the table. And then we kind of wrapped up with some themes. We seem to see that or detect that communication among the many different players in Yakima County is pretty broken, maybe too strong a word, but it's pretty fragile. So that was one outcome. I think that recognition and what to do about it. Second of all, there was, as you might expect, a lot of discussion about the capacity of the system in Yakima County. Should there be more? And that is to be seen. And then finally, there was quite a bit of comment about the cultural competencies of the providers of these crisis services for either the Latino community and the Native American community. So that's kind of the way we left it. I just popped the question at the end. I said, should we get back together? And most people really jumped at that. And so these two went. Wasn't I answered just in 3 months? I stayed another 45 minutes there, and some people said, well, I don't know if we're going to be able to move the needle in 3 months. So it might be 2 to 6 months, but I think there's a real appetite to check in with each other and see what's happening. And there was lots of good dialogue. I don't know if you two have any comments.
The only reason we would say 3 months is because if you wait 6 more months and nothing seems to be happening, you know, like checking 3 months if something happens or changes. Are they communicating? Are they doing the things that they said that they were going to do? That way we're kind of checking in on them. See if there's any reason that's really.
And I agree with that too. I think we need to keep the momentum. This is really an important issue. And something else I wanted to say is that before the meeting, I think some people in the room had some tension around this area. I think people here know the background here with Comprehensive and some of the other organizations. Joe Vila had a written speech he wanted to give. But before we began, Catherine Soluskin's father, who's a council member, gave a prayer, and he also sang it as a chant with a bell and singing. And then Patrick gave a quote from Abraham Lincoln about the tensions leading up to the Civil War. And I think that was really important because it sort of changed the tone and the mood of the audience and sort of brought people together towards trying to achieve not I said, you said, but rather let's come to a common understanding. There were a little fireworks. Catherine Saluski got up and made some very pointed remarks about some of the organizations involved. But that aside, I thought it was very constructive.
So are you saying you want to do this in Walla Walla?
Yeah, and I'd love for you to facilitate. I have a note to reach out because we have a very active suicide prevention work group and suicide prevention campaign called Reach Out. And I just got it. It's just so timely. I got an email last night from one of our community health advisory board members that he had been on hold for 3 hours on the crisis line after hours to get help.
Yeah, we heard stories like that today.
I mean, it's just unacceptable.
Yeah, and I think that there's.
I'm not saying it's one organization that's involved in crisis.
Right.
It's very difficult, but also it's the county and local government. We are to determine who contracts, in some ways, especially for the state block grant dollars, with going through the BHASO now, and then also talking, with how those dollars are going to be going through the MCOs and how they're going to be going for them. And so there's just some accountability that's not there right now.
I think that there were a couple of standout comments. One was at the very end, the sheriff, and I think he was from Sunnyside?
Sunnyside.
Yeah. So the Sunnyside sheriff, there were a lot of law enforcement there, actually. His comment was that he was on his way home from some incident, and he heard that there was a suicide call from a high school, but there weren't any DCRs available. There's supposedly a DCR, a designated crisis responder in Sunnyside, and then I think there's like 14 DCRs that Comprehensive has in Yakima County, but there wasn't anybody available. So he sent his DCR because they have these run-alongs from a True Blood grant. He sent his DCR to the high school to intervene. And so we think that having better communication within all of the DCRs within Yakima County is one way to address part of the problem, because DCRs, it's not like, and I thought Courtney did a good job of explaining, it's like staffing up for the holidays and having retail clerks then not having anything to do after the holidays are over, right? So you can't anticipate the needs of crisis during any particular time of the day. So your staffing requirements are really tricky. Yeah. And so I think that there is opportunity technology-wise of creating these more robust communication networks, right, within, and with using maybe some funding that we have within the GCACH to help technology connect with some of these resources. So I thought that his was really important. And then we had the emergency room physician from Sunnyside, Dr. Cohen. And, he said, when you think about a crisis, if you have a heart attack and you have to wait, 2 hours, you're probably, and just because you're having a mental health crisis doesn't mean you should be able to wait 12 hours. So these crises are real. It's difficult to keep people that are in crisis sitting in an emergency room for more than 2 hours because a lot of times that they'll leave. So I just thought that there was some really good comments. And then Gilberto Yáñez from the migrant farm workers also spoke, and he said, our community is 80 to 90% Latino, Hispanic, but there's clearly a need for more DCRs that are even bilingual. They have 4 mental health, I think, professionals that are bilingual, but there could be opportunity for more bilingual DCRs. So, and I think that that's a really important point because they have a special population that they deal with a lot of stress. So I just thought that there were some really positive comments that we can pick up on and help improve the system. And I think ultimately it was Robbie from the Healthcare Authority said Ricky's Law was really promulgated and there was one person behind this law. He said, so it might not be the best law, Ricky's Law, in the land, and then he encouraged all of us to take a look at the law and see what we could do policy-wise to strengthen some of the laws in the state of Washington. Because truly, waiting 12 hours for a crisis response or even 2 to answer a phone call, when you're having a heart attack, you don't think that 2 hours is acceptable. Well, why would you think that 2 hours is acceptable when you're having a mental health crisis? So we might need to do some policy advocacy is all I'm saying on this issue.
One of the persons here that you can think of the app for someone's having a heart attack. That, you know, if you register on that app, and if it comes up within so much of me, I would get a thing on my phone and say, you know, and so we're trying to get that immediate response for, like you said, a heart attack, and have systems that are building around that.
Isn't that what we're trying to do generally? I mean, by sitting here, that's the whole deal. Yeah, it was the incorporation of, what we call that, integration.
Yeah.
Yes.
When you said technology, I just thought, well, that's an example of trying to get everybody that can help connected, so when someone needs help, at least someone should be able to.
One of the good comments was, so let's say, because she had said, well, there's only 8%. There's only 8% called. And he goes, well, what if I had only 8% of people having heart attacks? They'd still be held accountable for those 8%.
Yeah.
So,
Yeah, Dr. Cohen can do it.
Point out that, you know, that 8% needs to be focused on just as much as everybody with a health problem.
Okay.
Just a request, if you're hearing things like this in the future, you can make sure the NCOs know about it, because I don't think any of us knew about it. Technically, we're the ones contractually responsible for the Medicaid crisis, and we just delegate that to the ASOs here. Really? Yeah, so it's our financing that flows through us down to them. And we actually have to delegate functions like the 24-hour crisis line to them for Medicaid. And so if they're not performing well, we actually are the ones who are ultimately responsible for holding them accountable. And then we also have a lot to do on the back end of crisis when it comes to helping people get back into the community. So that all transfers over to behavioral health, not crisis. So it would just be helpful to make sure that we're involved in a lot of the conversations. Additionally, it's most likely going to happen that the plans eventually will get the risk for the civil commitment at all for state hospitals. So ITAs become critically important, especially related to forensic splits. So we need to start being a part of the conversations now, because we have a lot to learn on how to do that, and we don't want it to fail if it ever comes over to us. So there's just a lot of involvement, and I think people keep forgetting the MCOs have anything to do with this anymore. So
I'm sorry, we have been more than welcome to come to the school.
I know, it's not even your fault. None of us, I mean,
We didn't realize so much. We had it went from the healthcare authority to the
DHO.
non-Medicaid crisis.
Especially the state block grant dollars, right?
The state block grant dollars also come, yes, but some of them do still come from us too.
That was purchase block grant.
Yeah.
Yeah, so definitely.
Jason, and maybe before Megan leaves, we're heading Monday, Tuesday, and Wednesday to provider forums in the 3 cities, as you probably all know. And this is the place where the behavioral health providers will be asking questions. So I think we need to understand a little bit more of where did you guys end today, and what is the answer, what's the plan for the crisis system? Because the crisis system will be presented. So the 4 MCOs and the crisis system will be presented those 3 days in those 3 cities. And the what?
Yeah, come on.
And Walla Walla.
Whoa.
Oh, we
Yeah.
should
I
use
didn't even know
there on
that.
Wednesday.
Walla's on Wednesday.
So Wednesday,
Did I know?
9 a.m., 1 p.m.
The
behavioral health
program. So for the integrated managed care, so the people who are translating. Yeah.
Anyway,
Well, I'm there on
these are
Wednesday all day.
traditionally, sorry.
Yeah, no, that's fine.
Because that you
Yeah,
call
you
and
want
say
to
hi.
send me the
Please,
Thank you.
we have Q&A sessions, and what we have been doing is opening Tacoma. Those are those questions coming from the behavioral health providers, the directors, clinical directors, and CEOs of all behavioral health providers will be coming. So if there's questions about what the crisis is, what happened with this meeting, is there anything going to happen, it would be good for us to know, because our teams today would not have any answer.
Well, I did record it, so I can. Oh, great.
Oh, great.
Yeah.
You can put it into podcast mode and send it to us.
Sorry, you don't need any more.
The Lori's on the phone.
Okay, good. Thank you. I just,
I'd just like to wrap up. So the And so to answer your question, Jorge, there's a lot that's still in motion right now, and I was real pleased for those of you from Yakima to see how cordial people were to each other and just really engaging after the meeting. So I don't know all the ins and outs of those side conversations, but they look pretty engaged. And so, as you may imagine, Jorge, you can't create a blueprint out of something like this.
It is a very
without having smaller group discussions, and I think that's going to start happening. And perhaps if we follow the West Diane Maxim in 3 months, then lay down the law that you guys got to have something done, then maybe there'll be something there.
I'm just a little curious, Diane, because the Early Warning System work group
Yes.
that is meeting here and still meeting for 2 months, was this part of the conversation with the?
Yes, that's actually how it started. It all started in the Early Warning Systems work group. We had a couple people from the jail there, counselors that go into jail, and then they said that they would call for a responder to come in, and nobody would come in for hours and hours and hours. And so then it got brought up that it was happening in Yakima, it was happening in Benton County. So they wanted to have a separate meeting to talk about it. So then Healthcare Authority kind of got involved, and we had one little side meeting and decided that it was going to have to be a Yakima separate and then Benton County separate because they wanted separate meetings. So then this progressed, and that's how we got into it.
But at the same time, as Drea,
Yeah.
Toppenish is also having some issues, so it kind of morphed into a Yakima County meeting and probably more Yakima Nation centric because they're working closely with the Drea Hospital to try to solve some crisis problems. But I think that the Yakima Indian Nation is a special case. They've had 2 suicides in the past week, so it's it's prevalent. There's a lot of suicides that are happening on the reservation.
We wanted to kind of ask you if you guys don't know this. So for that incentive funding that we received, so we let the BHO help us decide the formula. So the BHO, are they contacted with the Yakima Nation to provide services now? Should they have been factored into that formula?
So my role is speaker service unless they opt to manage care. Same with the BHO, they're carved out, so they're not visiting me now. And maybe on crisis.
That's what we were kind of wondering, do we need to like address that, should they have been involved in that incentive funding?
Yeah, we're getting their network from them. Okay. We'll know that for sure.
Yeah.
What we can tell is that so far, most of the tribal members are BHSO only. So they would not be on the managed care system under the BHO. So tribal providers would likely not be contracted with the BHO.
Okay.
Except potentially for crisis services only. Okay. We don't want it to work that way.
Okay. We didn't talk about that after the meeting, and I thought, was that something that we missed? Because I know when we originally did it, we missed the residential. I just didn't want it to come back on us to be like, well, why did we miss the application?
I don't think they are, if they would be a procedure crisis, but they aren't for INC.
Okay.
But their choice, and usually accommodation does not contract with family manager. Okay. Okay.
So any other questions for Patrick?
I'll just say I thought it was a good start.
Yeah.
There needs to be a lot of conversations. So, yeah, first guy got this meeting about that. Yeah, we'll go.
Okay, thank you, Patrick. Thank you, everyone who participated.
This is Tanya. May I say something?
Please.
Hi. I was a part of that meeting as well, and I think, our biggest concern is that we do have a very high suicide rate, and I do hope we do a meeting within 3 months, because in 5 weeks we've had 2 completions, and in 5 weeks, 5 weeks, and so I off branch into the schools, daily, and this puts our youth at a higher risk, not only because of their survivors of suicide, but also because we have such a alcohol and drug epidemic right now on our reservation as well. And so, you know, we have many factors, and the one thing we kept hearing is that it starts before they're even called. It starts before they even call. You know, there's other factors, and we know that. And I think the part that's hard for us is that we're hearing, well, we need to educate people on how to respond to suicidal ideations and how, you know, and we do that. I think what the misconception here is that we're all trained. Our program teaches QPR to the schools, to the community, to our tribal programs. And so it's not that we're not educated in dealing with the situation at the hand. It's that when we make that call, that's our last resort. And I think that's, you know, the part that we're trying to get out there is that we are educated, we are following the steps, we are implementing strategies to keep them safe and safety plans. And when that doesn't work, that's when we're reaching out. I think the other thing that we need to understand is the sheriff said that they would share, you know, some of the responders, the crisis responders. However, because of jurisdiction issues, when we call to 911, they dispatch us to tribal police because we're enrolled Yakima. So we don't go to the sheriff. If they're on tribal land and we're tribal members, we have to go to tribal. So how will that crisis responder help us if we always get transferred to tribal police? And I think that was one of our issues is why can't we have someone here when we have such a high risk population and we always get dispatched back to our tribal police? It's kind of like they don't have all the tools that they need like the other departments. And so those are just some of our concerns. So I do hope that this meeting will happen, you know, in the 3 months and not the 6, because like I said, in 5 weeks, we've lost two members. And this really affects the community very heavily because a lot of us are related to one another. So it affects a whole community in that way. And I guess that's just what I wanted to make sure that you guys kind of understand our concerns.
Okay, very well said. Thank you. Okay, any other conversation on this topic? If not, then okay. So we're down to discussion items. The first one is the CSI portal for provider reporting. Wes?
Yeah, so there was in addition to your packet, it's an SBAR. Everybody have this? I handed it out. Hope everybody has a copy of this. So at the Practice Transformation Workgroup meeting, we made a presentation, or actually CSI, which is an IT vendor, made a presentation to the PTW about two things. One of them was a portal for reporting and a landing page. And they also gave a presentation about learning collaboratives. I think there was a little bit of confusion, and this is probably my fault as I set up that presentation. The CSI portal is something that we pretty much decided upon. We're now looking for the board to authorize this. We're going to go through the discussion about what led up to that. We also received a presentation about learning collaboratives. We were not thinking that there would be necessarily a contractual relationship with CSI. If it worked in our best interest, there might be. That was simply a vendor presentation to show what they have to offer. It was also part of an educational process for the PTW to understand what's involved with learning collaboratives. Learning collaboratives in general could be open to CSI, could be open to CMMI, the organization that Mike Hindmarsh belongs to. It could be PNWU, could be the AIM Center, it could be a variety of organizations. So I just wanted to give a little clarification about that. Do you have questions about that? So at the meeting, Brian Sandoval asked, had we done due diligence before selecting CSI? And we're going to ask for the presentation to be given to the board. So this is why we're putting this on today. So as some background, what we're looking for is an online tool that will serve two main purposes. Actually, there's a variety of purposes, but I've grouped them into two big areas. One of them is to be a reporting tool so that organizations that are going through practice transformation which we're going to look at here shortly, those organizations have the ability to report on their progress with their change plan or their PTIW. If you want an online tool that will allow that. Either they can upload an Excel document or fill in a form. We also want a landing page where project areas, practice transformation organizations, other individuals that might be tied to the learning collaboratives, and maybe even the general community at large can go to access resources. So we're looking for kind of an all-in-one tool. So those two components, the reporting portal component and the landing page component, are the two things that we want this product to have. The landing page component must have the ability to upload and download documents. So if Sam belonged to Tri-Cities Community Health and she wanted to see what's going on with their practice transformation implementation work plan, even though they have a copy, it would be embedded in a directory that's within the landing page. It's not in a directory that's assigned to them. Of course, there would be permissions and user rights, so only she could access that file folders and the navigators, but not necessarily other outside organizations. However, there may be other file folders that have permissions that everybody can enter into. Let's go ahead and scroll down. I'm going to kind of just run through this. Another qualification that we want for this minimum viable product is the technique that Rob Arnold, who's with the Health Commons, told me about. He essentially said, when you're creating something like this, you want something that developed with only enough features to satisfy the early implementers. And then once you adopt, you add on only as needed, rather than coming up with a big technology solution that might have a lot of features that don't necessarily add any particular value. We want to take a minimum viable product approach. After that, if you scroll down, cross-ACH proof of concept. This isn't necessarily a core requirement, but if other ACHs are using this tool, they have something favorable to say about it, we find that favorable and it supports the tool as well. Also, if it has a good reputation in the marketplace, if it's being used in some of the other districts around the country, that too has some favorability. Finally, in terms of this qualification list, we want something that is inexpensive, easy to maintain, and has flexibility in terms of our ability to adjust it as needed. So then we go on to the assessment part, and here we talk about some of the tools. Now, there are a lot of other tools that we've looked at that I haven't brought into this for one reason or another. They just clearly weren't in line with what we needed. Spectrumetics is a good example that was used in New York. It's a very extensive tool, but essentially it's built up for provider organizations, which were not. So Zara DRBS is a tool that we looked at. It's linked to Upstream USA. Upstream is the organization that presented to the Leadership Council several months ago about intentional pregnancy planning. If organizations agree to work with Upstream, Zara automatically comes along with it. Upstream is essentially what we refer to as a population health management tool. It has patient visit planning, clinical integration, registry reports, referral management reporting. All of these are components of what we traditionally would consider to be a population health management tool. It's a very appealing interface. It has tons of measures pre-built into it, which I really liked. The problem with it is that it has to be hardwired into the organization. So rather than using a web form or uploading an Excel document, there would have to be what's called an HL7 feed between the provider, each of the provider organizations that are involved. So that increases the scale and scope of the implementation and also extends the timeline. As well, there's no capability for a user landing page to upload, download documents or to do collaboration. That's an example of what some of the tools on Zara looks like right there, those screenshots. The next tool we looked at is LifeQI. This is a software tool currently being used by Pierce County ACH. Again, this is another tool that we really liked. It has a little different flavor. It's not necessarily a population health management tool, but it's one that really fosters quality improvement. They have these driver diagrams, which you can see an example over here on the right, where the expected outcome is on the left, and it kind of works upstream to look at deliverables that will support the achievement of that outcome. Then each one of those boxes has a linked-in measure. So it's kind of an elegant approach to process improvement. It also links in PDSA, Plan, Do, Study, Act cycles with charts and measures. And it has run control, or what they call SPC charts, to show how you're doing using a time series with error bars or control bars. There's also dashboards and some other nice features to it. Kind of like with Azara, it has some limitations. Again, there's no real landing page feature. There's a minimal landing page feature. Also, it has to have that hardwired capability to the provider organization. So in terms of landing pages, one option we looked at was the University of Washington Practice Transformation Support Hub. This is developed with Healthier Washington along with Qualys Health and with, again, the University of Washington. This is a hub that Olympic is using. It's basically a web resource portal where they can post information, and organizations that are tied to practice transformation and their version of it can go to access information. There's also training workshops, virtual learning events. In a lot of ways, it's kind of like Slack or Dropbox. Problem with this is that they're not very price transparent. It seems to be very expensive. It doesn't have any reporting capabilities. And to be absolutely honest, their financial sustainability at this time is somewhat questionable, whether they're going to be around for the life of the demonstration. That's my interpretation. Let's go on to the next one. The fourth option would be a SharePoint custom build. There's other tools that you can use to do this, but essentially we would be building a specific website linked to our main website that would have all the features and the requirements that we would want. This, the cost around this is uncertain. It all depends on how many features we would put into it. The timeline for this would be extensive, and there's some other drawbacks to it, but it would give us absolutely the greatest control over what we wanted to see. And it wouldn't be a separate website. It would actually be a part of the GCACH central website. Final one, the one that we're choosing is CSI Solutions. This is currently being used by Olympic Community of Health, North Central Community of Health, and North Sound ACH, Kettleville Community of Health. The person that founded this was somebody who helped with the original implementation of what was called the Wagner Care Model, the Wagner Care Model, which is now part of PCMH. He was involved with the national implementation of this. He's worked with private organizations, public governmental organizations, and more. He has an extensive amount of experience. If you scroll down, this tool has tons of particular features. The nice thing about it is that we're able to take the tools currently being used by the other ACHs, where there's crosswalks between the measures they're using and when we're using, it just automatically put it into place. So the timeline for adoption would be shortened. In terms of flexibility, there's flexibility built into the tool as well. Because the other ACHs have agreed to use this tool to sign contracts, we're actually getting economies of scale pricing. So it's less expensive than some of those previous tools. And again, it has a lot of quality measures built into the tied into the National Quality Foundation, NCQA, HEDIS, and more. There are tons of measures that can be used to meet our needs. So the flexibility that we want, if you scroll down a little bit more, Lauren, the web data entry portal would look something like this. This is just a sample of questions. That first one is blood pressure control. I believe these are for diabetes. Actually, there's just some general measures. The second one is the use of imaging studies for low back pain. So we would custom design these measures for each individual organization that's going through practice transformation. So when they go in there, log on, they would pull up a sheet or a web form that would be based on what we've designated or agreed to with them to their change plan. That's just a quick run through. If you want more detail, you can read through this. The budget for this has already been approved. What we're asking the board to do is simply allow us the authorization to just go ahead and start contracting with CSI for the portal. And the cost of it will probably be between somewhere around $40,000 to $50,000, depending on how much we put into it in terms of the design.
So, if my memory serves me right, and who else here was this a practice transformation work group?
Kira
Board
was.
members, okay. Any of the other board members? My recollection was is that the work group had recommended that you get some staff people that work in this kind of thing to test drive this before we made a decision.
Okay, we haven't done that. We've actually seen 2 presentations from them. We have a full hour video that shows North Central and OCH in terms of their implementation of the product, but we haven't set up a demonstration where we've driven the product.
So I think it's fair to say that that was the recommendation from the work group, that they thought it was important that some people put their hands on it.
Okay. Okay, we'll arrange that to happen. So some time when we can go in there and play with it.
That would be great. I'm sorry, Madeline, you had your hand up.
Oh, I just wanted to clarify, is that an annual ongoing cost or is it?
That would be an annual fee. That would be an annual fee. Jorge.
If I can clarify the suggestion from the practice transformation team, I was there, it was to select 2 or 3 current providers that have a QI department and ask them, a representative from Yakima Neighborhood Health, a representative from Austria, Tri-Cities was there, and Veronica has a number of questions about that. So if 3 people from different providers could get together and do some kind of step on as the actual users that they will be of the system.
Okay. This one seems to not have an integration with electronic health records. So would this require someone to go in and pull data out of their EHR and put it in? Is that what I'm seeing?
It has the potential to do that hardwiring, I call it hardwiring, the HL7 between the EMR and the software. However, that changes the pricing model. And so what we would like to do is to have them either have the ability to upload an Excel document that has fields where they put in data, or simply go into an online web form that would look like this where they hand into the data.
But you have to get the data from somewhere to begin with. So that means you're going to draw it out of your EMR and then upload it or key it in.
The organization would have to extract the data. And Sam and Jenna and Martine know more about what specific measures the organization is going to be reporting on through their change plan. That would be on a quarterly basis, and we're about to go look at the model that talks about the distributions. But we think that completion of this would be the triggering event for quarterly payments.
And I'd just add on to answer part of Les's question is, if right now, any primary care provider, any care provider that's contracting with a managed care organization is having to extract this now. So that's the
same data.
Well, we haven't seen, they're going to be part of the core measures in most cases, right?
Yeah.
Who said yes? Okay.
We're going to try to align it with the MCO. I think that's what we're talking about.
It's just I know from working you had one more thing for them to do.
That's right.
They are not very happy. But you make it easy. You make it consistent with what their practices are, and then it can work. But
I think that was a big part of the discussion that we had, was making sure that the people that are actually going to have to do the work have a chance to put their hands on it. And hopefully they'll feel as good about it as others.
I'll work with the navigators to get something set up to where we can do a test run in the next week or so, because we need to get this moving pretty quick. In terms of the measures that the provider practices are going to be working on, I would have to say, how far along do we think we are, Sam? 80–90% of the way? In terms of that 80. Yeah, and so we're developing, Sam's put a ton of time developing a very comprehensive user or implementation guide. Yeah, it's good. It will be very helpful. It's really helpful to have something like this because it explains kind of the background and reasoning. There's a milestones document that will accompany probably the provider contract. So I'm trying to provide a lot of detail about what the expectation of reporting is. We understand it's a little bit of work, but we're talking about big dollars here in terms of provider organization payments. So this seems like a reasonable amount.
And I would say at the very beginning of the reporting, it's not going to be your HEDIS measures. It's not going to be the P4P measures, not right away. It's going to take a bit for us to get to that spot. I think initially it will be more milestones toward PCMH. You know, are you impaneling patients? Do you have a risk stratification tool? Or do you have disease registries? Are you, you know, I don't know, what are some of the other, yeah.
Advisory council.
So a lot of it will be attestations that don't necessarily lend itself to an EMR extraction. Down the road, yes, that's the opportunity.
So, I mean, I work with immunizations a lot, and one of the problems, we have a great immunization system in the state, WAIS, it's wonderful, but many providers don't put their stuff in.
To Leslie's point,
So that's the point, is how do we get it so they're gonna do it?
I've just flipped, how many providers? 38 to a new IT system, new EMR.
Yeah.
And I don't have anybody showing up in my office complaint. I have them in my office all day, every day, hammering me about the 14 more clicks they got to do today.
Yeah.
Today, much less these patients. I mean, your point is dead on. If those providers have to draw one more piece of information, they just won't do it. And I don't mean to be a negative person about it. You just got to find a way to make it supportive and make it less painful.
So the providers are part of the practice transformation process. However, this piece in terms of the data aggregation is probably going to come from the quality improvement team. So there's a little bit of separation there in terms of asking providers to do. Now, there may be some other things that are involved in the work here that might involve more clicks. I mean, certainly we're very sensitive to that. You know, we went with the prescription monitoring database into their medication summary list, but if it's not, that involves another click or two, that's going to be worth the effort to see if we're taking opioids.
I just don't want to derail a great project with something stupid, because really what it was that.
Right. In terms of pay for performance measures, healthcare authority is going to report on that already. They're going to report at the GCACH level how we're doing. So we'll be told from them through the claims that come from the managed care organizations. There may be some reporting requirements. We might ask for one or two measures just to show they have a process in place to do that sort of quality check using data analytics. There will be some pay for reporting measures, but those are pretty straightforward. Yeah, are you using opioid guidelines?
Yeah.
Stuff like that.
Yeah, and that would
straightforward.
And again, I don't want to lose sight of what we're trying to accomplish. I would keep that in mind as we proceed. We've got the doctors adding a thing.
I think it's a good point. There's run out a lot of different levels. I mean, 'cause even when you take it away from providers and you tax it, our QI team was one more thing. There's this level of burnout there, and we don't have the greatest widest. We're not sitting in Silicon Valley where we have a workforce we can just pick up any extra QI person. A lot of us, and so I think it's just good to just be mindful of it.
Yeah, we have one.
Yeah,
for the hospital.
And that's where a lot of the competition was at the current
Yeah.
transformation work group, was about the QI team.
Yeah.
And they had the capacity.
So the measures in the book that we talked about probably will be done by the next board meeting. We're going to a symposium next week. We're going to be reporting on, every ACH is going to report on what they call their intermediate set of measures. And we consider this our intermediate set of measures. So not only will we be able to talk about what we're doing, we should be able to report out on what other ACHs are doing as well.
Good. Thank you.
A question on, so you said that what would be reported now would just be more like the quality of attestation. But for the paper performance, when we do get to that point, is there, I can't remember in the new data guidance if there's guidance on the baseline, or do we need to be collecting that now so there is a baseline?
That is part of their assessment when they're going out.
Thank you.
Right. It's built into their change plan. There's a number that shows what their initial was and then their stated goals for each organization.
And it's also listed on the tracker.
Okay, so are you looking for a motion of some kind at this point?
And you can amend it to include a test drive by the QI team.
Do we need a motion? I guess we're going to be adopting something that we need a motion.
I need a contract.
We have a forum still.
We do, and Lori's on the phone.
Megan's on the front phone.
Okay. So is there anyone that would like to make some kind of motion?
This is stipulation that some of the base people and users have shown
Is there a second to Julie's motion? Second by Carrie. Is there any further discussion?
What's the result if CSI is test driven and does it meet the SIP test? Bring back a different proposal.
We'll have to come up with something else.
What, are they gonna allow us to do that without signing a contract?
Find out.
Well, maybe we can go to the other ACH and do it, like, I mean,
Actually,
there.
that's a good idea. We could work with,
North Central.
North Central, right? Either North Central or OCH, see if they'll.
They can do like a demo.
Yeah.
We'll sign a contract if they can give us some sort of a demo mode for the software.
Well, we've actually seen a couple of different demos.
Right, that we could actually click and play with.
We call them playful.
I think that's a good idea. That's a very good idea.
Actually, Central is going to get us access.
That's why it's such a good idea.
Okay, is there any further discussion? Is everyone clear on the motion and what you're voting on?
Yes.
Okay, then all in favor?
Aye.
Enthusiastically? I'm trying to read next here to see. Is there, we've only got a half an hour to go, you guys. Is there anyone opposed to the motion made by Julie? Is anyone abstaining? Taylor. Okay, thank you. Okay, so now we're on to the revenue sharing model concept crosswalk. It says Sam, is that you?
Yes, that is me. Okay. The Practice Transformation Work Group has requested that for the tracker, those descriptions that are listed within each one of those categories be crosswalked over to the associated PCMH change concept. And this is just a document to relate to that. Several of them have different areas because there's different workflows or different deliverables within this area. So if you have any questions in more greater detail on that, it will come in a different document. But as Wes said, there's like 80 to 85% of that done. But just wanted to kind of give you guys a crosswalk to look at the component and look at those different categories that it goes into the PCMH crosswalk course. Is there any questions on that?
Can you want to talk about the link and the points?
You can.
Well, so we, this came out of a model that Dan Bazzouli originally created that we modified to those categories, and we sat down as a group, and with a lot of help from Sam, who knows this like nobody else, put a rank value tied to how important each area was. So if something had a rank of 1, it was very important. And points were assigned correspondingly to the higher the rank. So the rank was between 1 and 3. The one outlier here relates to reporting, which has an exceptionally higher rank. Jen, you want to talk about that just for a minute?
Yeah, the reporting has different areas, meaning reporting is also the transparency within your organization, being able to display those, to report that to leadership. The quality improvement team has a huge opportunity to be able to implement these reporting tools. Again, it's not something that's going to be cumbersome, Brian. It's more of a narrative.
You're the only one.
I'm very respectful to that. Coming from a residency program and being able to work with 28 residents in one setting and 11 in another one, I understand that we do not want to make this a cumbersome process. We really want to be able to implement these strategies and workflows and work with the organization on where they want to go, what their goals are, and give them a couple of different options. And some of them they're already doing. And so if we can make it just a smaller version of what they're already doing or a larger version and the same data comes out, that's what we really want to do. That's optimal, right? And so, yeah, reporting is a huge one because we want to make sure that we are not only looking at with our internal organizations, but we're also benchmarking against other organizations of the same capacity and size, so that we're making sure that our mentors, our exemplar clinics are going out and being able to assist those other clinics. What are you doing in your practice? How are you reaching these goals? And
So there's a lot of different things in that reporting that, and I think that that has the hugest weight. So we want to be respectful that all of these categories are going to go into that reporting, and I think that that carries the largest weight, and we want to be able to see you guys funding out for that.
And so then just the overall picture is that this rank order and these categories, these components are tied into the funding that the providers will receive. So we didn't bring you the revenue model because we didn't want you to go agog of the numbers. But once we have the board approval on this revenue sharing model, we can plug it into a revenue model, and you'll be able to see how much each one of these things is actually worth to the organization.
And again, we wanted to be able to give a aligned model of what that looks like so the organization don't know that there's a non-biased decision to be able to approve the method as opposed to what the organization actually does.
You have stuff on the back.
Yes, but that is exactly what Wes was going over, the different rankings and the weight and how they go into the 100%. But this is more of the funding model, and so whenever you would see what that actual calculation of these different assessments, so each time that these organizations, so 33 of the primary care partnering organizations as well as 12 of the hospital, each time that they would reach one of these metrics, say the assessment, that's a one-time deal, you would receive 2.38% of that funding at that time.
Can you remind me what the red color?
I'm not sure. What is the red on there?
So the red color, the red color relates to measures that are particular for just that particular type of organization. So primary care has access and continuity of handling of patients, risk stratification. You go down to the graph below it, those aren't there, but hospital care management is there. And essentially, the weights from those three above are combined here at 16.67, because hospital care management is unique to the hospital, where those other three measures are unique to primary care.
I'm sorry, I was a part of that decision. I just went blank for a minute.
No worries.
But it also, we want to make sure that the hospital association or the hospitals understand that theirs goes into that hospital care management, and all of those calculations in the three categories that are listed above for the clinics is actually the exact same that you want.
So are you looking for approval of this?
Yes.
That's what you're looking for. So are there any other questions? And if not, would anyone like to make a motion about accepting the revenue sharing model?
I move to approve the percentage revenue model.
Second. Second by Sandra. Is there any further discussion or questions? If not, all in favor?
Aye.
Is anyone opposed? Is anyone abstaining? Okay, great. Moving right along, the Lynn Network update. This is Becky Rubin. You're Becky Rubin.
Well, we had our, council meeting today, we had the main events were CBO Fair and the Lynn report out. It went very well. I think it was well attended. We had the usual number of people out here this meeting. In addition to the CBOs, there was some crossover there too. We had, I think I counted 15 CBOs and very, they were varied from housing, from food security to programs based in schools. So I think it went well. I don't know what everybody else thinks, but I think it was a good idea to have them both in the same field. I saw a lot of people meeting, just all the people for the first time, CEOs, talking about what they do and some of the activities this programs have. So I think people went well. I know most of you were here and told me where it, but what did everybody else think?
I thought it was great to hear all the different counties areas of focus and some of the things that they were doing. Nice presentations.
I saw a lot of interaction, both before the session and with people mingling and going to each other's tables. The room got pretty loud there for a while. So that was a good sign.
We've heard from other ACHs that this is a tough nut to crack, is that community clinical linkage. So,
This is the best one I've seen so far. It went very, very well. And the fact that having the 5 means, because here we have a unique challenge, is having 5 regions as opposed to one county like Maine on yourself. This went very well because everybody got to see what every region was doing and share a little. So it was really, really good. And then there were other CBOs that most people didn't know about, so they got to talk about their training programs, etc. It was really interesting.
We would call that brief and sassy. Okay, great. Yeah, great job. There was a lot of enthusiasm in the room this morning, so that was very helpful. So the last thing we need to talk about is our board member roster, and we have 7 members whose term is up in January. And so I've asked Sandra Suarez to chair a nominating committee for us, but she needs some help. So I'm wondering if there's a couple of volunteers from the board that would be interested in helping Sandra review the nominations and bring recommendations back to the board.
The thing I noticed that we still are saying 1-year term and 2-year term, but as of January 1st, they're all 2-year terms.
Right.
So this whole column is.
Will change.
It will change.
Yeah.
This was so for the initial year, as you recall, we all picked numbers out of the hat, and then that determined the cadence of the sector representation.
So are there a couple of volunteers that would like to help? Ruben? One more? One more?
But I'm up for my job. Maybe I shouldn't do that.
I don't think that's a problem.
I don't think it's a problem.
So you tried to get out of it, but I think let's just volunteer. Mike or Ryan will help too. Okay, there you go. Great. Thank you all for doing that. And our hope is that you'll bring recommendations back to the December board meeting if that's possible. And then
point of process is you don't need to have our recommendation, right?
that's correct, because you're in a separate process.
Yeah, we do. I know. Like some boards, we actually still have to have it approved.
Guys get to self-determine.
Okay.
As the bylaws say.
Yeah.
So before we adjourn, we always want to make an opportunity for public comment from anyone who has not had a chance to speak before the board. So is there any public comment? If not, this could be a 25-minute yes as well. Is the,
It gives the time.
So yes, the time. So is there a motion to adjourn?
So moved.
Is there a second?
Second.
Okay, well, the meeting is adjourned. I don't even have to call. All right, well, thank you, everyone. Good job. A lot of stuff. Good job.